Just waiting for Mark Miller to get on. So I got a lot of stuff for you tonight. We are going to be doing the Sports Doc Show. I'm remote. I am in Miami Beach for the U.S. Soccer Sports Medicine meeting put on by the AOSSM and AMSOM, and it's been a great meeting so far. A lot of good stuff today, and we're going to be talking a lot about some soccer injuries. We're also going to be talking about a lot of the injuries from the last week in sports, and hopefully Mark will be on in just a minute. I am just setting my stuff up here. As you know, we don't have a producer yet. Waiting for one. I'm happy to find one. Or I'm happy for somebody to volunteer. I am looking for anybody that might be on. Let me go down from here. And like I said, guys, I am trying to figure this one out myself. All right. Still waiting for Mark to join us. All right. So let me know if anybody is out there. Let me know if you're actually watching. I would like to know. Just because this is like the first time we're doing this in this way. So let me know. I have my Facebook up and I'm waiting for it to see. All right, Mark. Well, I see Carrie's on. Hey, Carrie, how you doing? Hope you're having a great night tonight. Uh-oh. Here's Mark. Hello.
Hey, man, you ready?
Yes. You calling on Zoom, buddy? Because we're on live right now, actually. so, so join us. We're going to be editing a lot of this at some point. All right. Hopefully. Now, actually. So join us. All right. I'm trying to see who's out there. I'll tell you.
Hey, who's joined us tonight?
Oh my goodness! Look who's on. How you doing, Ian?
So you're live on Facebook right now.
You got to talk, buddy, or else you're not going to get on.
Say hi to Dr. Palumbo.
Hi.
It's bedtime.
Mm-hmm.
And then after you go to bed, Daddy and Dr. Palumbo are going to talk a little sports medicine.
All right.
That would be great.
So, Mark, we're on live right now. Because it was 9:15, I figured we'd start and I'd let people know what's going on.
Heck yeah.
I am still trying to figure out if we have anybody putting any comments in or anything because I have about 4 things I'm running here. But you
know what's great? The fact that you've traveled and we can still do the same exact thing no matter where you are.
Yeah, I'm hoping people appreciate it.
It's a little bit different setting now.
Yes.
You're at it looks like you're at a hotel, correct?
I am. I'm at the Lowe's on Miami Beach, and we are I'm at the sports medicine sports medicine society's U.S. soccer, actually FIFA meeting for sports medicine. So it's been a great meeting so far. Getting into a lot of stuff, so it's good.
So this is a FIFA meeting that is centered around sports medicine, correct?
Correct.
So I take it you're talking about a lot of soccer-related injuries and preventative and things that we would see in a typical soccer population.
Yeah, and today was really a lot of on-field stuff. A lot of we start off with like heat injuries, and then we start off with did a lot of stuff on conditioning and a lot of the new research that's going on with hopefully injury prevention and that. So hopefully it's I think it's been well received, so it's been pretty good.
That's fantastic. All right, buddy.
What?
It's bedtime for you.
Oh.
Hold on.
All right.
Let me. Buddy, I have. For those of you that are out there being patient, I appreciate it, because I am obviously not doing this right. I see no
That's the joys of a podcast.
When you hear that snap,
Hold
it's
on,
a quick of a snap and flip.
Buddy, I have.
That's what makes me
sick.
sick.
I appreciate it, because I am obviously not doing this right. All right, Mark, are you there?
I'm here.
All right, we're good. So I'm going to assume that we're on Facebook, buddy, because
well, it does say on the top of my screen, live, recorded live on Facebook. So,
all right. And do you see anything coming through?
I'm going to assume that to be true.
Okay. All
so
right.
If I log on to Facebook on my handy dandy, here we go. Oh, the joys of technology.
Oh, buddy. I said I already made the announcement that I need a
Have you had anybody apply for the job yet?
No, after watching the last one, I'm not sure anybody will.
I will tell you this. We have some guests lined up
look
for some of our future weeks.
Oh, okay. Very good.
So I'm pretty excited about a lineup of some pretty knowledgeable sports medicine individuals that we'll be announcing quite soon. So
that's pretty cool. Hey, we do have look. It's Carrie Urban. Fryman is out. And she asked us, "What's the most common injury in soccer?" And it really depends on what level you're talking about, and it depends if you talk about the men or the women. But obviously, ACL is one of the most common. But one of the bigger injuries that you do see are hamstring and quad injuries, and then ankle injuries, then knee injuries. So that's one of the most common things that you will see. And obviously, the most severe one of that would be the ACL injury, because that almost always requires surgery for a player. So obvious that's of concern. It looks like hey, Jamie Scalise is on. One of our great certified athletic trainers. He's at Muhlenberg right now. I worked with Jamie for 17 years, Mark.
I can't believe that. I honestly
seasons. I've been on the football field for 17 seasons with him. And it's the first year I'm not. So, but it's good to see. So there's a lot of stuff to go over today, buddy. I mean, we have.
Well, I don't even know. We can just start with quarterbacks if you'd like to.
We can do that. And,
about a quarter
wait till
of
you
the
see
league.
this technology I'm working on. Wait till you see it.
I cannot wait.
I don't know if it will work, but wait till you see.
So do we have some on-screen visuals for everyone?
Oh, we are going to. There we go. I just that's the way I wanted to look at it. So where do you want to start?
Well, I mean, I think the one thing that we want to talk about the injuries to our quarterbacks right now. There's lots of injuries to talk about, and the good thing is that if you do want to get away from the Antonio Brown drama, this is the place to go because we're a sports medicine show,
Yes.
and there's nothing to talk about from that regard as the Patriots release the much maligned wide receiver. So
I can't
has
imagine somebody who loves the Pittsburgh Steelers is must be very upsetting for you.
it hurts deeply that he is currently unemployed on his third team and has made a mockery of his own career. So, but like I said, we're not going to talk about that here on the Sports Talk, the OAA Sports Medicine Foundation show. What I do want to get into is his former teammate, because I think that this is one of the most interesting injuries. It's not one that we see too often, and primarily we see it in football in quarterbacks more from a traumatic standpoint. Whereas I don't find any evidence that this was a traumatic injury, and that's Ben Roethlisberger, who's going to require Tommy John surgery. And if I'm not mistaken, he had surgery already this week to repair that ulnar collateral ligament that knocked him out of last week's game. Obviously, it was probably not last week's game that caused the elbow injury. It's years of playing quarterback. And I'll let you talk about it a little bit, Dr. Palumbo, as to why we don't see this in quarterbacks like we see it in baseball pitchers.
Well, I'm gonna try to find it here. Nah, we won't get it on. But I was gonna show a picture of it. But basically, it is unusual to see. It's not unheard of, but it is unusual to see in professional quarterbacks that the injury occurs on the inside of the elbow, what we call the medial side of the elbow, and there's a small ligament there called the ulnar collateral ligament that basically attaches the upper bone, the humerus, to the ulnar. And what it does is, as you're bringing your elbow out to the side, and you're basically, see, I could do this today because I don't have any green screen, but here's the elbow. The ligament is right over here, and when you're cocking back and coming through, you are producing a lot of stress on that ligament. It's very common to have that injury basically from attrition, from from a lot of injury, a lot of use, and finally it just goes. I agree. I did not see it hit anybody's helmet. I did not. It didn't look like an unusual throw. It was, it just tore. And if it's almost any other position on the field in football, it's not something you're going to fix. Whereas in quarterbacks, you almost always have to.
And the interesting part is, in our baseball population, the mechanics of throwing a football and the mechanics of throwing a baseball are completely different. Throwing a baseball, it's one of the only actions in all of sports that goes from a dead stop, and play begins from no motion at all to a very violent motion to the elbow and the shoulder. And we're talking about, as we've talked about before on the show when we were on the radio all those years ago, is that the ulnar collateral ligament is really a wisp of tissue. It's a very small ligament in the body, and we know that in cadaver studies, the ulnar collateral ligament fails at about 33 Newton meters of pressure, when we know that the average baseball pitch is much more closer to above 34. So it's amazing the amount of force that it takes to tear the ulnar collateral ligament, and the fact that it doesn't tear more often. Now, there's a lot of other structures, directly around the elbow, the pronator teres, which is one of them. Another injury that we see in baseball players a lot, and that ligament itself is protected by a lot of other structures as well as the biomechanics of throwing. But we also know that the more you throw, like we've said before, there's only so many bullets in the gun, and after a while that will start to wear out. But we do know that there we go. Look at
you like that, huh?
I love it. That's phenomenal. Look at that. The
So
sports doc coming into the there we go.
So this is the ulnar collateral ligament. As you can see, here's the upper arm. here's the ulna or radius, the two bones of the forearm, and it really is a short ligament. Now there is a big portion of muscles and tendons that also attach right up here, and it's the dynamic strength that's in those tendons that really allow it to allow to actually the elbow to be thrown past load. And you could see in some of these, some of these positionings more where you could see how they're cocked back and the stress they're putting on that elbow. And it's I realize I have to turn. I'm like running three things, Mark. So, but
again, we have a posted position for a technology.
Yes, we do.
Producer.
But I was trying to show, I was actually trying to show the actual anatomy a little bit better, but it's not going to happen right now. But we'll figure that out. So yeah, it's so the way we reconstruct it, we usually use a tendon that's already available in the forearm. It's called a palmaris tendon. It goes from the wrist up the arm, and it's a nice, perfectly sized tendon for the for the use. And basically, what you do, there we go. You put it through drill holes, and I'm going to show you. I'm going to show you the classic Tommy John surgery as described by Dr. Job. Let's see if I could share that with you. Mark, you're getting scared that I'm doing this, aren't you? So
no, I love it. The fact is that we're on Facebook Live. We're not on ESPN, so we can do whatever we want.
Here we go. So this would be the palmaris tendon, and you have two holes or a tunnel where the original ulnar collateral ligament inserted, and then a tunnel that starts where it originated from, and then you weave this tendon through this area. It's usually done through a split in the tendons that are there. And it's, this makes it looks like a big area, but it's really not. It's a small, small incision, small tendon. But what you're seeing here, this tendon is actually far stronger than what the actual native ligament is. So, it does work well. It does do its job. You can imagine, though, technically, you have to be right at the appropriate areas of the origin, appropriate areas of the insertion, and the tension's got to be right. So obviously, it takes skill to do this. But as far as reconstructions, it usually does well. Now, I say does well, but still, in professional pitchers, even though we see so many pitchers come back and play, it doesn't mean everybody does well. And so it's something that you never want to have to go through. Now, with a football player, actually the returns are actually better with a quarterback, because they actually put less stress on their elbow, and it's the technique of throwing a football, as you said, is completely different than throwing the baseball.
And that kind of brings me, I can't wait to ask this question. So we talk about that palmaris tendon that we use in reconstruction, but the palmaris tendon only, not every person has a palmaris tendon. So when we don't have a palmaris tendon, what else do we use for reconstruction?
Well, there's a very common tendon that we use for ACL reconstructions. One of the two hamstring tendons that we use is called the gracilis. It's the smaller of the two that we use to reconstruct with, and we get that from the knee. So usually get it from the same side. You make a little incision over the insertion where the gracilis is. Harvest that tendon and use that. That's a real stout tendon. I mean, it's big. So you may even do a different technique with the gracilis, but for the most part, we use the same technique. As I said, the reconstruction is far stronger than the from the native ligament. It's very unusual to tear your ulnar collateral ligament twice. It's unusual to have to do the reconstruction twice. When you do, it's often has to do with technique. The biggest complication or the biggest problem with the reconstruction is when you start developing ulnar nerve irritation, or you had ulnar nerve irritation before the reconstruction and you don't do it as part of the procedure. So certainly that's one of the things that you have to go back for occasionally, is to then do the ulnar nerve release and transposition. But I know there's a lot of doctors out there, including the great Dr. Andrews, who does it on every case.
That's a great point too. I was just going to say, I mean, the amount of ulnar collateral ligament reconstructions that you've done, or for that matter, most have done, it seems to be that nerve transfer is kind of becoming commonplace, almost to the point where you don't want to have that problem. So if you
have to really prove to me that you do not need, like, the ulnar nerve is just quiet. Now, obviously, you never want to take something that's fine and do something to it. So, but often, especially in chronic injury, that nerve starts getting on a stretch and starts getting irritated. So it's not unusual for that to happen. For you to need to do the transposition originally. And I would say, well, I don't want to make a guess, but I know there's been some studies on those of us in the Sports Medicine Society that do the procedure, that it's definitely a majority that will do the ulnar nerve.
And from a rehabilitation standpoint, this is very interesting, because the rehab obviously out of the gates is very similar to what you would see in a baseball pitcher. However, the chances of Ben Roethlisberger coming back and playing for the start of next year are much, much higher than if he were a baseball pitcher. At a pitcher, you're looking at usually about 18 months till you return to the mound. Although,
a little bit better now. It's funny, Mark. Mm-hmm. We went from, that pendulum. Every pendulum swings in orthopedics, and so we went from 18 months to 2 years to people were trying to go below 8-9 months, and now we go whoops. So and because really it takes so much to get, and this, Mark, you've rehabbed many of these for me, and it's not just the elbow, it's not just the arm strength, it's all the core strength, it's all the scapular stabilizers, all that needs to be done. So but no doubt, I mean, all goes well, he should definitely be back. He should definitely be back by next season. Because that's, I mean, it is really truly almost a year that he has, so I would expect him to be back. Again, it's a different motion in quarterbacks, and so I expect him to be back.
I kind of shifting gears a little bit to the next
I have to. There's a funny comment. Can I tell?
Please.
You'll like this. Good friend Jim Shepard out there goes, AB, I'll make it G rated. AB is the only, oh, it was NFL. I thought he meant something else. NFL player to have his jersey on the clearance rack in 3 cities at the same time.
Isn't that the truth? I mean, he's 9 months. The guy's played for 3 teams in 9 months. And he's suited up, 4 catches and a touchdown. There we go.
But we're not going to talk about him.
No, not on this show. No, and it really blows your mind. I mean,
yes, but we're not going to talk about it.
No. So the other future Hall of Fame quarterback that has a little tiny ligament that's creating a big issue in his career is the fabulous Drew Brees, the quarterback for the New Orleans Saints. Sustained a thumb injury. Now, this was a traumatic injury. This is an injury that I call it a grit your teeth injury, because after a coach sees this happen, he just grits his teeth like, oh, you've got to be kidding me. nobody wants to see this happen. It's the worst thing, the way to get injured as a quarterback, because it's not like somebody busted through and hit you low. He released the football. His hand collided with the hand of an outstretched defensive lineman, and that was it. You can't tough your way through this. You can't grind your way through this. And, he knew it after the game, too. He couldn't grip a football. He couldn't hold the football with his thumb. And he ended up having surgery this week. And that is very commonly known as a gamekeeper's thumb in the world of orthopedics. But I'll let you kind of explain a little bit more about what a gamekeeper's thumb is. And
let's see how I do again here, man.
Love it.
Hold on. There we go.
Love it.
Oh, we'll have to go through these and see. But as you can see, here's the thumb. Okay. And this is the joint, which is corresponds to the knuckle. We call it the metacarpal pharyngeal joint. And there's a ligament on both sides. And this one on the inside, what we call the ulnar collateral ligament, is the one he tore. And again, you might imagine to grip the ball, you need that stability here. Even though there's a tendon that inserts in the base of the thumb here, which often gets caught in the tear. Quite honestly, that's one of the problems. It can get caught in the tear and it becomes hard to reduce this well. But normally this does avulse off one side. Let's see if we have that.
If I'm not mistaken, the tendon that gets caught in that tear, is that not, do they call it a Stenner lesion?
They call well, look at you. Here we go. And that's, you could see that's this, you could see where this gets pulled off on the base of the thumb here. I don't know if Drew Brees had any bony injury, and often the procedure is fairly simple. I don't want to say anything is simple, but for certified hand surgeons like the 4 we have at OAA, it's a fairly routine procedure. Small incision. They use little anchors that go into the bone right here. And I realize I'm moving my. I don't know if. Can you see my?
I see it perfectly.
Okay.
Your little cursor.
Yes.
There.
Okay. So the cursor is working. We're learning here, folks. So you see where this is pulled off, but normally the ligament runs right here. Often gets pulled off of this side. You put a little suture anchor into this area here, and then you just tie the ligament down. And then obviously you have to protect it afterwards. The big question is, will he be back this season? And we've started using internal braces on a lot of these ligament injuries, which is really just a strong suture type material that bridges the repair, and it's like an internal splint. And I'm not sure. Obviously, I'm not sure what their surgeon did, but they are doing some additional things now that make these repairs of the ligaments a lot more stout. You could move them earlier. Okay, so you could start working on the motion so they don't get stiff. You could start working on some grip strength early on. So it's certainly something that I would expect at least 6 weeks before they allow him to get back. And who knows if the obviously if they do well the rest of the season, he may be back by playoffs. But if without Drew Brees, we'll see.
And Drew Brees, the team is now stating they're thinking more like 6 weeks. I don't even think they put him on IR, which means that he would have to be out for a mandatory 8 weeks. So this will be interesting to see where this goes over the next few weeks. Obviously, I always laugh when I hear surgery is a success. Have you ever heard of a pro athlete having surgery to reconstruct or repair an injury, and they come out and say the surgery was a complete failure? We cucked it up completely. His career is over. I've never heard that. So you always get the reports that the surgery is a success and
Shocking.
good. It's glad to hear it. So but I don't think they put him on IR. So
No, not yet. Again,
yeah,
there is, listen, if they're if they're 6 and, well, no, if they're 3-8,
yeah.
he'll be back next year. He's not coming back, so, but it really depends on, obviously it depends on, you know, how the team does.
So last week we talked about Sam Darnold and the fact that he is out indefinitely right now with mononucleosis, and we talked about some reasons for that. And his
They
backup,
did
Trevor
report,
Siemian,
by the way, that he does have splenomegaly.
yeah,
He does have an enlarged spleen. So yeah, I wasn't sure of that last week, but
it's funny. I've been
obviously that
listening.
needs to be protected.
I've been listening to a lot of the talk shows and people talking about he is contagious, which yes, that is an absolute issue when it comes to mono. He is, he has a lot of fatigue, and we know that too. But you and I have said it, which is the part that people don't emphasize enough that drives me nuts. All of those symptoms are important. However, the splenomegaly is the most concerning. You cannot play you can't play sports, period, with mono because of that reason. You rupture
You don't
that
want to
spleen.
jump hard on your bed.
No. That is the main reason why these doctors are so concerned about him. All the other things are important. However, it's the splenomegaly that is the problem. So we don't talk enough about that. And the Jets, of course, played a Monday night game, the much anticipated game. The Darnold versus Baker Mayfield lineup or matchup, but that didn't happen. And Trevor Siemian comes in the game. And Dr. Palumbo, you posted a fantastic video. I don't like to say fantastic because obviously the injury is not fantastic. However, the injury itself, and here it comes. I love it. Look at us. This is it right here, and this is
so Mark,
yep.
Watch this. Watch his ankle here. All right.
Yep.
Watch it come down.
Right,
watch it come down. Now comes down. There's where it goes. Okay. See how it rolled out? That's not an inversion injury.
Nope.
That I think is a subtalar injury. I think it's a low ankle joint injury. Now watch.
Yeah.
It's out. It's a lateral. It looks like it's because there's no way it would be out laterally if he didn't fracture anything over here.
Right.
He didn't. So now watch this. As he comes down, he hits the leg, reduces it. I was shocked. When he was able to come off the field, walking on that. But it just shows that if it was what again, I wasn't there. I'm a second opinion doc, but I haven't seen this one. What are they doing to me? All right, let me get out of here before something inappropriate comes on. So, but yeah, that's so the good thing about that, first of all, if it was reduced, obviously they got x-rays in the training room, and the first thing you're looking for any fracture in the ankle joint itself, which is where the ankle bone is underneath the shin bone, and then the lower ankle where the heel bone is up against the ankle bone that's the joint what we call the subtalar joint. Okay.
Mm-hmm.
And the amazing part of these injuries, they could be completely out and have to be reduced in the operating room, and they could still not need any surgery whatsoever. In fact, usually if there's no chip fracture as it goes out and it doesn't catch the tendons on the way in, which they can get incorporated between the two bones, and that's a bad thing because that needs surgery to actually get the tendons out. But again, in a subluxation, I wouldn't expect it to be out that far where the tendons would have to be reduced. So, and again, he wouldn't be walking on it if that was the case. This is a very stable reduction. In fact, the biggest problem with this injury is the subtalar joint gets stiff. And so yeah, there's a lot of bone bruising. There's a lot of injuries that you want to protect him for, but this is one that you don't necessarily even immobilize if it's solely a subtalar subluxation dislocation. So that could have been more of a disaster if it was completely out. There's some injuries that can occur with it that including devastating injuries that I just don't think it could happen and walk off with it. So I'm thinking this is a pretty good scenario for him.
So the Jets are now down to their third string quarterback, Luke Falk, who's actually pretty darn good. He was 20 of 25 in the game. So
right.
Unfortunately, they are rolling into to play the New England Patriots this weekend. So there's not a lot of hope up there in New York. It was interesting when he went down.
Is there any hope for anybody in the AFC?
No, there's no hope for any team in the AFC except for the Kansas City Chiefs.
And there may not be any hope in the NFL.
No, I don't think there is. I mean, I if we're going to talk nuts and bolts football, I don't. When New England is playing this well early, obviously are they unbeatable? No, they're not unbeatable. No team in the NFL is unbeatable. The Miami Dolphins could go out and win a game this year. I don't know if they will, but they could. Just as the New England Patriots, can lose a game this year. They went 16-0, a few years ago, and your beloved New York Giants took them out in the Super Bowl that year. So, and
yeah, I'm gonna have to hold on to memories this year, my boy.
Well, the rest of the football universe is very thankful of the Giants that year. But I don't know. It's just Tom Brady is he doesn't look like he's ready to retire next year. He doesn't look like he's ready to retire in 2 years.
They actually showed a picture of him his first year, face shot, headshot, and one of this year. He looks so much better, like so much more fit now than he did back then. He was like a pudgy faced kid back then.
Now it's like the backup quarterback who's now starting in place of the injured Nick Foles down in Jacksonville, another starting quarterback hurt. Gardner Minshew, these with that mustache, he looks 10 years older than Brady right now. And he's obviously a 23-year-old rookie. So that's another thing to talk about, as well as what he has been able to do to keep his body. And if you look at all the greats, it's not their mind, it's not their football mind, it's the body that goes. And a lot of times it's not even the arm. Dan Marino could probably, when he retired, throw a football just as well as he could when he was a rookie. It's the rest of the body that goes with it. Peyton Manning's kind of an anomaly. He had that neck injury that really almost ended his career, and the fact that he came back from that in at all is a miracle. So these guys, the fact that he's able at 42 years old, yes, the TB12 method, it's his method. And I like to say it's his method. It's him taking a lot of different science and combining it into what works for him. The things that he's doing are not researched and breakthroughs. They're stuff that works for him.
That and witchcraft.
Yeah, that too. And he probably I sold his soul to the devil a few years ago as well. I think a lot of Patriot haters would be happy to hear me say that. But we have a lot of respect for him though as well.
No, absolutely. Listen, you can't listen. I wish he was on our team.
Everyone does.
Listen, come on. I don't know. I mean, what's amazing is the if you look at the amount of sacks and hits he's had, it's like somebody's been in the league for 5 years, 6 years. I mean, it's for somebody who's that immobile. He just sees the field and gets rid of the ball so quickly, and he doesn't take a lot of chances. So
and he doesn't. The funny part is that you said he gets rid of the ball quickly. He doesn't throw the ball away a lot. which
No.
means that there's someone open all the time.
How
And
is
and
Julia?
it's just
How is Julia Edelman always open?
it's just I, I don't know. I mean
The guy's
the
5'2".
he is, and he's not a career receiver. He became a receiver,
He was a
when
quarterback.
he was a quarterback at Kent State University. So go Golden Flash, by the way.
Unbelievable.
The but the things that he has done through diet, through fitness, the sacrifices that he has made, and to prolong his career this time. Here's a fun fact: he and I are the exact same age, both born August 3rd, 1977, so we're the exact same age, and I look a little bit better than he does, I would have to say.
I would say that.
Obviously.
Yes, Mark.
I feel that my NFL career has just begun.
Yes.
No, but it's amazing to me that he is able to still do this at a high level. And if you think about it, the rookies that he's playing against, were 2 and 3 years old when he came into the league.
It's crazy.
So that kind of leads us down the path to another starting quarterback that will not start this week, and that is Cam Newton. Sustained a foot injury in the preseason, and last week it was reported that he aggravated it. The Panthers are calling it a foot sprain. That concerns me. The reports are that he needs the week off. They don't want it to get worse. They don't want to aggravate it. But Dr. Palumbo, foot sprains don't get better, and they really are. I don't expect this getting better at all this season if he's going to continue to play.
Well, and Mark, we talk about this injury I'll say the injury that we suspect. And let me just put this one up here so we could go over it a little bit. All right. So my suspicion is, when we look at this, is that we're dealing with an injury. So this is the midfoot, Mark. All right.
Yep.
We got that. And there is a little ligament that goes from this bone, called the medial cuneiform, to the base of the second metatarsal. And this little ligament, you can see the space that's opened up over here, is called the Lisfranc ligament. And you can injure anywhere along this what we call tarsal metatarsal articulation along here. But this is the one that's actually specifically the Lisfranc ligament. If there is a significant injury there, all right, and in this case, you could see the space between these two, and you could see that they split apart. The answer to this is it needs surgery, and usually it's by basically putting screws across this area to reduce it and hold it there. And then sometimes there's whether or not to take the screw out at 12 weeks. Some people do, some people don't. I classically do. But so this is typically what the midfoot sprain is. And like I said, it could go all the way over. And sometimes it's just on the lateral side, which is not as bad. But if it's on the medial side and there is a significant injury to that ligament, they may try to put him in a very stable shoe, with a very steel insole, and tape it and try to get him. But it's so hard to push off this foot when that is injured. So if it's complete, he won't be back. They may try to get him back. They may try to brace his foot. They may try to calm the foot down. These swell like crazy. So they may try to calm that foot down and try to get it so we can at least tape it and try a rigid cleat. But I don't see it happening. I just don't see it happening.
Yeah, and I think that it they're talking about this as being something that needs a week off, and I just, this is going to plague him all year. And if he does play on it, I fully expect him not to be able to play. Not to be able to play it at a high level. And for a player of his magnitude, somebody who depends on his legs so much, the other thing is about this injury is he's a big man. He is a big man. There's a lot of force that goes through that foot when he plants and cuts, and there's no doubt about how good he is, and he's always been known for a guy that will play injured. He will play in pain, the evidence of
really,
that.
Because that, how a bridge has a center stone in it.
Mm-hmm.
That the one that's right at the apex,
the keystone.
This is the keystone.
Yeah,
this is the keystone, and you lose that keystone, the whole arch collapses.
Mm-hmm.
And so, he doesn't want to. And then if he doesn't get a fix, and people to have this injury, even industrial injuries like this, if they don't get it fixed, and in the past, people didn't recognize it until it was too late. This goes into an arthritic foot, and usually you need to fuse that joint and to fuse that area so that it doesn't move at all. And I'm sure there may be somebody that has played with a Liz Frank injury like that. And I'm not sure if anybody has played fused. I don't know if that has happened in the NFL. If it has, and because these can typically occur in an offensive lineman, so it would be an offensive lineman. But for a quarterback to step through that and he's a mobile quarterback too. He's not a guy that stays in the pocket. He's
nope. Depends on his legs, and that's part of their offense too.
Right. Exactly. So that's it's a shame. And they're it's amazing. I don't know how much more they can protect the quarterbacks. They've made every rule change to protect the quarterbacks. It's just, it's a violent game, and it's just a lot of major guys getting hurt this year.
Yeah, and we talked last week about clavicular injuries, and obviously Nick Foles is had surgery last week to fix his clavicle after it was fractured in week 1, and there is, I don't think that, like you said, as we get into the NFL deeper and deeper, the rule changes that they're making are obviously designed to make the game, as they say, safer. And I think the game is safer than it has been.
No doubt.
I don't necessarily like at the college level the targeting rule, the penalties of throwing a player out for targeting, but they've made it quite apparent that you cannot make contact with another player with your head. Now, if you've never played the game, you can understand that this can be very frustrating and very hard. The youth levels, USA Football has done a lot with their heads-up tackling to try to really teach proper tackling. And you and I both know that some of the best players of all time weren't necessarily quote unquote headhunters. They were great tacklers, and there is a way to tackle without keeping your head involved. Now, your head will be involved no matter what you do in the game of football. It's impossible to take the head completely out of the game. But these rule changes are designed to make the game safer. I like to attribute it to what NASCAR did with their car of tomorrow a few years ago. Speeds were getting up over 212 miles an hour in qualifying in cars like that. And NASCAR said, whoa. Guys, we're going way too fast. We're pushing the limit, and we need to back this off. We need to create cars that are not going to go that fast. And that's what's going on in the NFL. And it's not
well, you can listen, the guys aren't getting smaller, and they're not getting slower.
No.
And so you have to find something else. And I don't want hopefully my wife is not listening right now, but it's a game I love, even though it hasn't loved me back. Obviously there's just so much you could do. The physics of the sport is just incredible. It's incredible. It's a 35 mile per hour and motor vehicle accident every play,
Every play.
and it's crazy. It's crazy.
And I just don't think that you're going to fix that you're going to make it better. And when I hear people say they're trying to make the game softer, my response is almost, yeah, but that doesn't mean that the guys playing it are softer. I just read an article last week, a great article on Vontae Davis, the quarterback for, he was a Miami Dolphin, was traded to the Indianapolis Colts, and then last year was with the Buffalo Bills. He retired at halftime of the second game of the season. He walked off the field, walked out of the locker room, and left the game. And then this article really kind of outlines, it was on ESPN.com this week, and it really just outlines, he had his aha moment in the middle of the game. His mind just said to his body, I don't want to do this anymore. What they don't realize, what people don't realize, is this game, the physical pain that you play in every week, and that you have to endure. And there's a breaking point for every person, where your mind just tells your body, I don't want to do this anymore. And that's a very real thing.
There's no doubt. Listen, Mark, I had the privilege of playing college football, started for 3 years, and now it wasn't a Big Ten school, it was an Ivy League school. Since I played, I had I had patella tendon rupture when I was in college, that was fixed, and I came back and played. But since I left Cornell, I've had 17 orthopedic procedures, including, partial total knees, both sides, a right total hip. I'm fused 6 levels in my lower back and 4 levels in my cervical spine. And that's, again, Ivy League football. Okay. And, but it's the mentality of playing through. And these guys, especially, I'm not talking about the guys that, get guaranteed $30 million contracts. I'm talking about these other guys that they don't know if they're going to get cut tomorrow. They don't know who's going to replace them. They will lie about any injury they have, any injury that they could play on the field. They will. And it's one of the hardest things, I'm, again, fortunate enough to be a NFL Players Association physician. So I'm on the player side, and, a lot of what I do is these injury arbitrations, and it's sad. It's sad what these guys go through and the injuries that they've had, and it's crazy. And so you look at a guy like Andrew Luck, who here's a guy who's, a Stanford grad, obviously a very smart guy. And, I have to say, for the most part, the negative statements about him retiring only lasted a couple of days. And it's, and because none of the players said anything. None of the players said anything.
Not at all.
And they know. He just knew he couldn't do it. He just knew he didn't want to go through another recovery. He knew he just didn't want to go through the pain of possibly another surgery. He gets it. And anybody who's been through it, especially these younger guys are just smarter about their bodies. And they have.
That's undeniable. And we're seeing more and more evidence of that. Patrick Willis, the fantastic linebacker for the San Francisco 49ers, he retired after 8 seasons. Calvin Johnson is a Hall of Fame wide receiver, one of the best to ever play the game. He retired much earlier. And these guys are, as the money continues to climb for the upper echelon players, it's not every player, not every player retires a multimillionaire. Yes, they retire wealthy. The average lifespan of an NFL player is just under 3 years. The ones that
those guys aren't retiring wealthy.
No,
those guys aren't retiring wealthy.
And if you have a myriad of health injury and issues to deal with when you retire at 6 years, if your work ability is limited, you're going to have a hard time making a living for yourself. And if your head and your mind aren't right, which is obviously one of the main concerns in the world that we live in today, what is your life going to look like?
one of the reasons why I got involved with uh, Coach Dicka's
Yep.
Gridiron Grades. Okay, and I was lucky enough to be medical. We basically founded the medical advisory board and for that organization. And what was happening back then? This was I guess '07 or 08,
Mm-hmm.
'07,
Yeah.
and at the time it was before the most recent collective bargaining agreement. And so there were a bunch of guys that were in their 30s. Okay. They, maybe they made a total of $1 million over their
Mm-hmm.
life, over their career. Okay. $1 million. And now they're 36 and they're crippled
Mm-hmm.
and they're uninsurable.
Mm-hmm.
Okay, this was before
Yeah.
this was obviously before the Affordable Care Act and all that. They were uninsurable, and these guys were just suffering. And they would, if they had one back surgery, their savings could be gone.
Mm-hmm.
If you're paying cash for a back surgery, you could be paying over $100,000, and
Mm-hmm.
that's just for the surgery in the hospital. And there's all the other stuff you could have.
And
So
that's one surgery, and the chances of that surgery fixing your problem is very minimal.
right,
So you've got another back surgery or two, or a neck surgery,
right.
or a hip surgery that's going to have to go along with that surgery. Yeah.
No doubt, no doubt. So, and our good friend Kerry just talked about the concussion,
Yes.
epidemic. I mean, you're right. Is it worth, when I played and when you played, when you played soccer
Mm-hmm.
and you were a goalie. So, I mean, we used to joke about concussions. We
Yes.
joked about it. We call it, hey, concussion club. It was like a red badge of courage, And if you got knocked out, that was even cooler, And how many times did my partner next to me on the line have to tell me what play it was, what count it was,
Yeah.
I mean, not knowing. And I remember watching films and stepping the absolute wrong way because I didn't know which way I was going.
Mm-hmm.
And we laughed about it. Now the good news is that we know so much more about it now, but even though we know so much, we don't know a lot. That's
No,
the
that
scary thing. We
and
we were talking about that today. That was one of the things obviously it's a big concern in soccer as well.
100%, absolutely.
I mean the head-to-head contacts, the head-to-ground contacts, the
Head to
how many
ball.
times? How many times? But and they're saying the ball is not. They did a lot of work with that, and one of the things they did mention today, it wasn't the ball as much as the head to head when people are
Mm-hmm.
going for headers, and but also, I mean, think about the collisions with the goalie. I mean, how many times, Mark?
Mm-hmm.
How many times did you lead with two fists to punch the ball?
Right there.
Yeah, that's what I'm saying.
See that little scar right there?
Yes, I do. Yeah,
Junior in high school, I came
but
out to save a breakaway, and I took one right in the face. Yep.
and you laughed about it. And you laughed
When I knew where I was, I laughed about it then. Yeah.
It's
My
scary.
yearbook picture my junior year is actually me with a black eye and 7 stitches. So and the reality is this isn't just a football problem. This is a sports problem. And
Absolutely.
we know so much more, and we're so much more to learn. And I remember listening to Kevin Guskowitz, the fantastic athletic trainer, PhD
Phenomenal.
down at the University of North Carolina. He's known as, the amount of the research that Kevin has done. It's phenomenal. And he was even saying when CTE came out as a part, the whole Mike Webster, and what Julian Bales and Dr. Bennett Amalu and the discovery that he made was very important. But what I'm saying is that it's not that CTE is not a real thing. It is a real thing.
But it can only be diagnosed when you're dead.
And we've started to scratch the surface on how to treat it.
Right.
There are lots of different treatment methods. There's a lot of people that believe that cannabinoids are a way to treat it. There are a lot of people that believe in in the I'm going to say this wrong because it's a little late and I'm kind of tired, but the pressure chamber, hyperbaric chamber
Hyperbaric chambers,
therapy.
yeah. Yeah.
Joe Namath feels that he's had over 60 treatments in a hyperbaric chamber and it's completely changed his life.
Right.
And who are we to say that those treatments aren't going to be effective? I think when you're dealing with the brain, I think there are lots of treatments out there, and this is just what I feel from the basic evidence is we know how to diagnose it in a dead person. We probably have an idea how to diagnose it in a living person based upon symptoms, especially in really terrible cases of it.
Right.
We don't know how to treat it yet, but I feel that because it can come in so many forms in different areas of the brains, that there's lots of different treatments that will affect people differently. And it's the key is, how do we narrow those down? And how do we figure out which treatments are going to work the best for each person?
Well, and hopefully, as our imaging
Yes.
gets better, as PET scans get better, as the
Functional
biomarkers,
MRI, yep.
biomarkers now, and and again, like hopefully once we get the biomarkers, then we'll know, okay, so this is a biomarker that is a byproduct of something that went bad, and once you figure out what protein or whatever went bad, well, maybe you could figure out what to do with it next. So yeah, there's a lot of research, and there needs to be a lot of research, because there has never been as many kids playing sports right now as there is now. And I have to say, I can't say I'm sorry about the trend of how big flag football is getting for youth football now.
Sure.
I think it's great. I think, listen, learn how to pass, learn how to catch, learn how to run patterns, learn how to be in a team. I mean, football is not brain, sir. It ain't brain science. It's not, you could learn it late, and a lot of athletes.
Actually, there's a lot of successful football players that didn't start playing until they were 8th and 9th grade.
Exactly, and so that makes me feel a little bit better, and now that we know a lot what's going on, but I do feel confident that we're going to figure something out. But obviously the biggest treatment is prevention.
Yeah, and that'll never go away. That'll never go away. One of my big concerns is, as we get better with the treatment of it, does that make us more reckless with the with the handling of it? And obviously, if you sustain a blow to the head and you do have symptoms that are on the concussion scale, consulting, having an athletic trainer on your sideline, so very important. Very, very important.
Huge. And the fact that we have protocols now, and
yes,
we're not getting, the coach. I think one of the biggest thing was basically the coaches are now out of the equation. Mm-hmm. They know they can't say anything. They know they will get in trouble if they try to influence anything in that way. And it just took some education for them. And so I think the coaches, even down to the youth sports, understand that, this is not something you mess with. And so I think that's, I think that's certainly the right step. Now, what I think is a disaster is that, if you go across the United States, how many high schools are not covered by athletic trainers?
No.
How many high schools are not? And in some areas, it's a majority. And that's we're part to me.
I forgive me, and if any of our athletic trainer friends are watching that do have the exact number, please go to our Facebook page and at the OAA Sports Medicine Institute and post under this live feed. Please, if I'm not mistaken, we're at about 37% of American high schools have athletic trainers, and it's not good enough. If you have the money to fund high school sports, you need to invest that money. You're already buying insurance for those. Buy insurance that's going to affect them immediately, and that's hiring a certified athletic trainer. I mean, it's so very important. Obviously that's my background.
And we're what's frustrating, we're graduating more ATCs than
Mhm.
there's jobs, even though there should be plenty of jobs.
There should be plenty of jobs everywhere.
It's ridiculous.
Absolutely.
It's ridiculous.
And not at just the high school level, but the middle school level. And even think, I spent plenty of Saturdays on the sidelines of youth football games in the area, covering lacrosse tournaments, covering um, soccer tournaments, having a certified athletic trainer, and allowing them to do their job and what we're trained to do as a profession should be every youth sport advice. It should be absolutely. If you if your first thought is I need this many balls to play, your second thought should be how many athletic trainers do I need to cover my high school soccer tournament, or how many do I need to cover my lacrosse tournament, and investing the resources in hiring athletic trainers, allowing them to put protocols, allowing them to have standard operating procedures, having a team physician overseeing those athletic trainers. That's another thing that people
They have
forget.
to. I mean,
You can't just hire an athletic trainer. They have to be overseen by a physician. Their standard operating procedures need to
how
be
many
signed off.
signatures do I have on standing orders?
Oh man, probably a little too much to make you a little nervous. Like, how many signatures do I have now?
Well, fortunately, the numbers are less. The levels are higher.
But it's so very important, and that's for a lot of we've talked about this before, for a lot of our viewers out there that want to go into sports medicine because you want to be a team physician one day. Being an orthopedic surgeon and being a sports medicine doctor and being a team physician, not necessarily the same thing.
No.
Being a team physician requires a level of commitment beyond that. And if it's hard to say, because medical school and orthopedic residency and sports medicine fellowship is a pretty big commitment in general. Being a team physician is a commitment even higher than that.
No doubt. No doubt. And, and it's frustrating when you see, I'll just say professionals and even physicians that are not trained to be there and probably shouldn't be there.
So. It's taking a phone call. You want to work? Everybody wants to work in pro sports or major college sports. You want to do that. You're taking phone calls at 2:00 in the morning when so-and-so's out.
Ask my wife.
Yes. When the Iron Pigs go on the road, the phone doesn't stop ringing.
No. I mean, and listen, after 25 years, it's the agents have your number too.
Yes, it's that we forgot about that part of it. But so that's having the proper medical care, especially in today's athletes, because it's even more. The commitment is higher. Athletes are getting stronger and faster, younger. The paces of the games are faster at the high school level, at the middle school level. I mean, collisions are real in football. These soccer games, these soccer players of today are so much, are trained so much sooner and are doing things at a higher level than it was when I played, all those years ago. So
the skills are amazing. The skills are amazing.
We have to be able to support them from the medical side of things.
Right. No doubt.
And when we need to be allowed, that's the other part. We need to be allowed to catch up to the preventative injury training and be a part of that process and not just leaving that up to the strength and conditioning staff. And that's another issue that, we got plenty of time to talk about these days on future episodes with lots of other guests.
Absolutely. So I think the Friday night deal was interesting. For those of you that are watching or will be watching this after it's not live, please put down your comments. Let us know what we could do better. I know what I could do better as far as running 3 different computers at once. But any comments that you may have, any issues you may want to talk about for yourself, any comments that you want to make, please comment in obviously in the comment section. Also, looking to see what day would work, what day
Mhm.
of the week. Obviously, we both both Mark and I have real jobs, uh, but we want to be able to do this live because we'd like to do it interactively.
Mhm.
And if you could think of another venue or whatever, looking to build. Or obviously, this is only our second show doing it this way. We're still learning. Hopefully, you got some enjoyment out of this, and but we'll be back next week. We'll be back next week on the Sports Doc, and please go to our websites at OAA, Orthopedic Specialists, and our foundation Instagram, and OAA Foundation Facebook page. And Mark, you have anything to push?
Yeah, we're gonna get music. No, like I said, be a part of the OAA Sports Medicine Foundation. It's the nonprofit wing of OAA Orthopedic Specialists. It's something that I've been involved in, for, believe it or not, 16 years now. And it's, our message at the OAA Sports Medicine Foundation is education, and that's what the point of this show is. It's fun for you and I. However, it's a really good way to educate people. It's a really good way to bring an open forum with a lot of today's most common sports medicine topics. Like you said, we started off today by talking about athletic injuries, and we ended up talking about a lot of the common issues that are plaguing our world of sports. And there are so many issues that we can talk about, overuse injuries and lack of rest. And we're going to get into all that. And I can't wait for our future episodes. So yeah, keep following us on Facebook. Let your friends know about it. Let's share as much as we can and get as many people involved as we possibly can.
All right, guys. We'll have a great night. Mark, thanks as always. And everybody out there, it's beautiful up there. And I know get out for the weekend. It's going to be awesome. Get active and enjoy your weekend. See you
All
next
right.
week.
See you next week, everybody.